I'm going to ask the panelists to come up and join me. Please. Sorry. What? You come next to me. You're next to me. Porcia. Manandhar. Okay. Manandhar. There you go. So, good afternoon, everyone. I hope and trust that the after lunch heaviness doesn't keep too many people away and keeps you awake, because we have a very exciting panel. I'm actually kind of looked over the presentation in order to prepare, and I'm actually very excited that we are covering a number of issues from very diverse perspectives in very diverse countries, which I think is one of the one conference strength. And I think there's a lot of learning we do, but one of the things that I have learned that everyone that's here on the panel uses multiple methods, because reality is difficult to gain when you don't do that. So they'll all talk about that. Our first, my name is Susanne Montgomery, and I'm going to be your facilitator, or the panel facilitator today. And I was stepping in for the original facilitator who was not able to make it. So if you came to meet her, I apologize. You'll have to put up with me, but I'm excited that you're here, and I'm excited about the panel. Our first presentation is pre-recorded. So I'm going to ask whoever is in the technical realm, there we are, to actually do that. It's a 12-minute, each presentation is 12 minutes. I have been asked under the threat of very serious things that have not been specified to keep to time. And we have big numbers here, so we keep to our 12 minutes, so we have time at the end to discuss. Okay, so I'll give you notice as you're progressing. This first presentation from Dr. Laura Skrip is actually pre-recorded. And Dr. Skrip actually worked in Liberia that was definitely decimated after many, many years of civil conflict. And then, of course, had the repeated shock of the West Ebola outbreak in 2014 and 15, and then multiple waves of COVID-19. Having worked in Sierra Leone, which had very similar challenges, I can tell you that the continued trauma has taken a tremendous toll on the population. And her efforts is how can you build up successive outbreaks, despite successive outbreaks, the trust that has been broken, that many people in the system are beginning to believe is no longer there for them and to protect them. So I think it's going to be a very interesting presentation from Dr. Laura Skrip. Briefly, Dr. Laura Skrip is, again, on video, and she is a quantitative epidemiologist with expertise in mathematical modeling. She teaches actually at the Liberia School of Public Health, Biostatistics and Epidemiology, my own training, and supports to engage students in practicum and thesis, and really encourages them to use participatory model and analytics in her work. Her goal is to collaboratively generate evidence that can guide good decision-making in very complex emergencies. So she really favors, even though she's a mathematician and epidemiologist, she favors a lot of mixed method tools, and I believe it'll be interesting to hear from her, though be it by video.
So hello, my name is Laura Skrip, and I am an associate professor at the University of Liberia School of Public Health. And today I'll be telling you a little bit about a project that we were doing with vaccinated individuals here in Liberia to investigate social, demographic, and clinical drivers of their vaccination behavior. Now, Liberia is a setting that is quite unique. It has had back-to-back shocks for several decades now that have jeopardized or sort of challenged the resilience of the health system, but also led to a lot of social and behavioral kind of influences among the population. So there's a history of recent civil conflict, followed by the unprecedented West Africa Ebola outbreak in 2014 to 2016. And then most recently, the ongoing COVID-19 pandemic, which is happening in the including ongoing outbreaks of measles, mpox, Lassa fever, as well as just high rates of other conditions such as maternal and neonatal mortality. As a little background on the COVID-19 vaccine situation in Liberia, Liberia received its first set of doses of the vaccine. It was AstraZeneca vaccine as part of the COVAX initiative in March 2021. And the government had put out recommendations to initially prioritize certain target groups, including healthcare workers, elderly individuals over 60 years, and then those who had known comorbidities. However, there was a lot of hesitance in terms of accepting that first batch of doses, and it largely went unused. And so ultimately, the government sort of opened up the criteria and allowed for anybody who had interest in getting the vaccine to pursue it. And so some ideas for why there was that low vaccine uptake initially had to do with the fact there were low reports of cases and deaths in Liberia. And this was coming just after people had experienced a much more kind of explicitly terrifying Ebola outbreak, where they were taking that more seriously than COVID. And so in some cases, this also led to disbelief around COVID-19 and that it was actually prevalent and affecting the population. There was increased interest in the COVID-19 vaccine once the Delta variant was spreading and Liberia was experiencing a more severe wave of COVID. So as of like June 2021, you started seeing queues at vaccination sites across Monrovia, which is the capital in Liberia. And it just, the disease was becoming more visible in terms of there were more deaths happening and the case counts were going up. And so people were starting to feel the disease a little bit more. And at that time, the country was reporting just over 4,000 cases, including 128 deaths. At this point now, all vaccine regimens are being offered, including the 2-dose AstraZeneca, the single-dose J&J, and then Pfizer as a booster. And to date, 4.46 million doses have been reported as being administered. So we undertook this study to better understand kind of the context of COVID-19 vaccination in Liberia. So we wanted to know who was seeking the vaccine, especially at a time when there was a small proportion of the population actually doing that, why they opted for it, so what their reasoning was, what their experience was during the vaccination and since they were vaccinated, and then thinking into the future how likely people were to accept an additional dose, a booster dose, or additional vaccines that might become available. And so this was a mixed method study that included a structured phone survey, because of some of the challenges and also risks of doing face-to-face surveys throughout the country at the time, and then in-depth interviews with a subset of those that completed the structured phone survey. And for this presentation, I'll focus primarily on the results of the structured phone survey, which was quantitative data in nature. And so these phone surveys were conducted with individuals who had been vaccinated. So those that were registered with the Ministry of Health as being vaccinees. And the Expanded Program for Immunization Unit, or EPI unit at MOH, kept a record of everybody who had received the vaccine. So we worked with the Health Ministry and the head of the EPI unit to acquire that listing and to randomly select individuals from that to form our sample for the study. And so we did want a nationally representative sample. We did sampling at the county level. There are 15 counties in Liberia. And that sampling was proportional to the size of the known vaccinated population in each county. And for conducting these phone interviews, this was a relatively new approach in Liberia. There's some skepticism, some concerns about scams that are being done over the phone. So we were conscious of that, but we also wanted to do something like I said, that was low risk when COVID was still prevalent and there was a lot of transmission occurring. And also, considering something that might be more cost effective and easily replicated in the future, even by EPI itself. So we recruited some of our Masters of Public Health students and trained them thoroughly in how to conduct these structured phone calls or phone surveys, how to communicate effectively and appropriately, especially given this anticipation of some skepticism among people receiving calls asking them about their vaccination experience. And so the phone survey covered quite a bit, but this included socio-demographic and clinical characteristics of the vaccinated individuals, inquired about the reasons for vaccination, the vaccination experience, where they went, how long they waited for the vaccine, and then any kind of adverse experiences after taking it. We also asked about history with Ebola, whether a family or a household member had Ebola during the Ebola outbreak. And then likewise, history of COVID, whether somebody in their household or family member had been diagnosed with COVID as well, to try and understand sort of behavior in the context of those close experiences with other disease or with COVID itself. And then we also asked about future vaccine acceptance. We did intensive awareness raising in collaboration with the Ministry of Health. Their health promotion unit included a lot of social media blasts about the project to make people aware so that if they got a call, it would be coming from a place of authority. Also, we used those posts to serve as a reference point. If somebody was questioning our intentions when we called them, we could at least direct them to the Ministry of Health and the school public health websites and social media accounts so that people could see that this was something legitimate. We set up a hotline where people could call with any questions or concerns, maybe before they consented to participate. And we also had videos kind of narrating an interaction where a family member who wasn't quite sure they wanted to participate was talking to someone who was sort of telling them about the study and why it was important to participate. And then likewise, we had radio programs with a perhaps larger reach than some of the social media accounts. Okay. In the end, we had 1,120 participants in our structured phone survey. We saw that there were a median age of 39 years, slightly higher proportion of males compared to females. There were almost 60% males who participated. We saw that low percentage reported having any history of chronic conditions that could be considered predisposing to severe COVID. And we did notice that the distribution of education was a little different than we might have expected in the general population. So almost 41% of participants indicated a university level education that they had completed, whereas the just finished 2019-2020 Liberia Demographic and Health Survey suggested 3.5% of females and 7.1% of the male population had education beyond senior high school. So we thought this was something interesting in that maybe the individuals who did seek out vaccination tended to have higher education levels than the general population and tended to be more likely male than female. Another thing that we noticed was that a high proportion of our participants reported close experience with Ebola. 6.3 reported having a family or household member affected by Ebola. And then in comparison, if we thought at the population level, only about 1% of households in the country had been affected by had been directly affected by having an EBD case in the household. In terms of the vaccines received and the experience at the vaccination site, study participants had taken one of all available vaccine regimens. So the highest percentage had taken 2 doses of the AstraZeneca, which had been in country the longest at the time of the survey. So almost 60% of participants had taken the AstraZeneca regime, 39% the J&J, and then there were very few who only were partially vaccinated with AstraZeneca or who had taken the Pfizer booster. And most participants reported being vaccinated at a health facility and waiting a median of 10 minutes to get their vaccine. When compared across whether somebody would recommend going to that same site or not, we noticed that those who would recommend the same site, the majority had gone to a health facility, whereas those who would not recommend going to the same site, a higher proportion had been vaccinated at one of the pop-up community campaigns happening in communities or at churches. So that was just something we noticed. When thinking about the reasons for taking the COVID-19 vaccine, we noticed that external influences played quite a role. So being recommended by the Ministry of Health influenced 53% of participants in their decision to go get a COVID-19 vaccine, while a slightly less proportion indicated that they did not want to get sick with COVID-19. And then other reasons were given, but were reported by quite a less proportion of the participants, such as it being required for work or for travel, or being recommended by family or friends inside or outside of Liberia. Now, given the high proportion of our study sample that had close experience with Ebola, we did investigate whether these reasons changed for those individuals. And what we found was the reasons were kind of shifted around. And so when we looked at those who had close experience with Ebola, we saw that some of the more common reasons being reported were actually about not wanting to get sick from COVID, and also that they had a condition predisposing them to severe symptoms from COVID. So those reasons were significantly higher among people who had a close experience with Ebola relative to those who did not report having that close experience. While this recommendation from the Ministry of Health being a kind of deciding factor was more commonly reported, significantly more commonly reported among people who hadn't had a close experience with Ebola. So some of these personal reasons seem to play a bigger role when people had experience with another disease in a recent outbreak. When considering future vaccination behavior, we did find that about half of the study sample, even though they had been vaccinated already, were unaware of booster shots and what they were. So that seems to be a gap. And that we also noticed that in terms of willingness to accept future vaccines, we asked about, for instance, a prophylactic Ebola vaccine. About 70% indicated that yes, they would be willing to accept that, but that meant that 30% of people who had accepted the COVID-19 vaccine, they either would be hesitant or have some uncertainty around accepting any future vaccines kind of targeting any diseases that there may be future outbreaks for. And this willingness to accept future vaccines did not significantly differ when considering people who had close experience with Ebola or even a household or family member who had COVID-19. So it didn't seem to be associated with these close experiences with severe disease. So in summary, the Ministry of Health clearly remains an influential source of information and is recognized as an authority. Based on how many people reported that as a reason, the recommendation of the MOH for them getting the vaccine. And so it's really recommended that there be ongoing and inter-outbreak messaging by this authority to promote awareness about immunization, especially for adults. And then this is particularly important considering the relatively high proportion who would be unwilling to consider future vaccines. This is among people who were vaccinated. Again, I keep emphasizing that because this represents a subset of the population that was already willing and accepting of the COVID-19 vaccine. It would also be great to use this phone survey approach to do routine temperature taking of the population around vaccine acceptance. Awareness of booster vaccination is low. And so I think that this could signal there needs to be reevaluation of recommendation around the booster vaccine, and depending on what the outcome of that is, to communicate those findings to the population and to increase awareness and understanding of what booster vaccines are. And then in general, one outbreak experience seems to affect the experience and behavior during a subsequent outbreak. So this needs to be kept in mind not only in Liberia, but globally as we now transition away from the COVID-19 outbreak, but inevitably will face other public global health threats as well. So thank you very much for your attention.
We thank Dr. Laura Skrip, wherever she is, and move on to our next speaker. Our next speaker is Miss Porcia Manandhar, and she's a PhD candidate at Johns Hopkins University and has done research on COVID-19 vaccine trust, inequities, and hesitancy in Nepal. And a little bit about Ms. Manandhar. She actually, before seeking her PhD, has gotten extensive work experience in international settings, mainly in measles. She also worked for the WHO and worked on maternal vaccines in general. Worked in a variety of countries, South Africa, I believe, Costa Rica, and now is in Nepal. And I'm very excited to have her come to the podium and share her presentation with us.
Oh, there you go. Hi, I'm Porcia. I'm from Johns Hopkins Bloomberg School of Public Health from the Department of IH. And I'm here to share my study on COVID-19 vaccine acceptance, trust, and inequalities in a low-resource district, Sarlahi, in Nepal. Although I'm from Johns Hopkins, we partner with NIPS, Nepal Nutrition Intervention Project, Sarlahi. It's a project that started in 1988 with the Department of IH and an NGO in-house in the country. And we have been conducting community-based trials, and most notably vitamin A trial, and cohort studies and surveys. My study was, the conceptual framework is from a socio-ecological model, and we looked at 3 different stakeholders and how we could engage those 3 in finding commonalities. The first one being in the public policy sphere. Aim 1 was to describe the country's vaccination and demand generation plans and how it worked out through the perspective of national stakeholders. This was a qualitative aim, and we had a sample size of 10. And for the second, the organizational level, Aim 2, we assessed COVID-19 vaccination readiness and acceptance among rural healthcare providers in Sarlahi. This one is a quantitative aim with 42, with a sample size of 42. Lastly, the individual level was our Aim 3, where we tried to identify the drivers and extent of vaccine acceptance and trust in government at individual level, which we did through a household survey of 363 individuals, again, a quantitative study. Nepal, it's a small country. Most people know it as the place where Mount Everest is. But I want to show you that the greens are all the rolling mountains, the grays are the Himalayas, but the lowest region, the orange, is the most fertile and flat place where the temperature goes up to 45 degrees centigrade. So it's really hot. And our field site is the orange little district, as you can see, and it's 9 hours south of the capital. And our study site where we did our project is in 4 different municipalities in Sarlahi. So I'll just jump into the results of Aim 1. The successes, and I'll be presenting successes and challenges, but we have 2 thematic areas. The first one being, in terms of successes of policy and program theme, was there was high level of political support for procurement and funding. And there was heavy reliance on EPI microplanning that started with polio eradication program in '96 and the Nepal Vaccine Act in 2003. So it was very easy to roll out COVID through this microplanning. Then there was a massive increase in cold chain capacity throughout the country. As one of the interviewers said, 200% increase in cold chain capacity, because previously in the 77 districts, we only had 1 in each district. In terms of challenges, like any other country, especially LMICs, we had a lot of supply chain problems and human resource shortage. And a big part of this population in the lower plains, which is also the most populated area in the country, is the fact that we have a lot of migrant worker families that work abroad. And during the second wave of COVID, that was a spillover from India, and we have a hugely porous border in the southern end, was a huge return of migrant workers from India, and that's when the country was just overwhelmed. And the second theme that we had was communication, and successes was great broadcasting through various medias. Radio and television is still very considered reliable in our country. And social mobilization was fast. We have this special cadre of non-medical professionals who are community volunteers. We call them FCHVs, Female Community Healthcare Volunteers. And social mobilization was done through them. They go door to door. And we also had massive co-branding efforts with UNICEF. And challenges was, again, demand generation was very difficult, especially in time of shortages, because the government was like, I don't know when and how to do it. And mandates was another big thing. We started off like following the recommendation, looking at age groups, and the only way you could verify that was with citizenship cards. But then once they removed it, because most of the rural areas, it's not something that people prioritize to have as citizenship cards, they didn't communicate that. So people were like, well, I'm just in the house, I'm not going anywhere. Might as well just skip all the vaccine drives because I don't have a citizenship card. And lastly, the government said they think the public have very high trust, which they do in the program, but there was dissatisfaction mostly because of during the periods of shortages. Then we move on to AIM2, the healthcare worker characteristics here, presenting our age. The median age was 39, ranged from 32 to 60. Majority of them were female, and as you can see, the female healthcare volunteers are all females. And in terms of professional training, which is medical training, we had a median year training of 2 years. And as you can see, for FCHVs, they don't have medical training. But for COVID training as well, it was a little low. It was 73% overall COVID-19 vaccine, as well as the disease infection training. But in terms of vaccine status, we see that about 71% were all boosted. There were nobody who was unvaccinated and nobody who just had a partial dose of just one dose. And moving on to AIM2 results, overall we had very high confidence in the vaccine, very high accessibility. However, there were still misconceptions about infection being caused by the vaccine, and there is, in the South Asian region, we practice Ayurvedic medication, and a lot of people thought it was effective against treating infection. 50% of the healthcare workers, oh, there you go. And then maternal vaccine this was a little striking finding in the sense that even though in the entire country we recommend all pregnant and lactating women be vaccinated, the healthcare workers were not confident in terms of giving the recommendation. And only 60% said they would recommend it to both pregnant and lactating, but the majority of them had misconception that pregnancy might be a very vulnerable stage and we don't want to be responsible if there was any negative outcome. And 16% said they will not recommend it to lactating or pregnant women. And in terms of areas of improvement, there was massive need that they showed of supervision and training. Like I showed before, only about 70% were trained, and it was only a one-time thing for half a day. And they needed updating. Surveillance of the disease was heavily demanded, as well as when we had a separate question if we had any other the areas of improvement, and it kept coming, the timely compensation for FCHVs by 64%. Then we move on to the last aim, the individual household level. Here we started off, so we had a census for 26,000 households from a previous big randomized controlled trial, and then we used that census to get 363 individual households. And then we hired 2 very great data collectors, and we ride motorbikes to each of the houses, and we use offline Google Maps was amazingly great in this area. And we just went back and tracked each of the houses and knocked on the door, did the randomization of every household member that was present, and then we did the interview. And population characteristics, median age was 35, age ranged from 18 to 86. We only interviewed adults or who can give consent from 18 years and above. Most of them were female. And in terms of education, 53% didn't have any formal education. Majority of them are Hindu, 81%. and 96% had high cell coverage. And again, the migrant family, we had 33% of the households who was receiving remittance. In terms of vaccine status, 1 in 10 people were unvaccinated. And as you can see, 50% had finished their primary series, but in terms of booster, we had a high dropout of only 20 people being vaccinated. But in terms of card availability amongst the only vaccinated, you could see 8 out of 10 people kept their vaccine cards. And they were kept with citizenship, money, land, paper, so they were considered very important because of the mandates that the government and also any other private banks, any government offices had their own mandates. And more key findings for AIM-3 was extended hesitancy. We made a score. We had 4 questions and we made a scoring of it. And there's 31% was more hesitant versus the less hesitant population. And out of the unvaccinated, 88% wanted to get the COVID vaccine if it was available. But as you can see, about 20% delayed their vaccination before getting them. And concerns, there were a lot of concerns about safety and effectiveness, but there was high accessibility. Although when we asked about if there was barriers, they did say waiting time is long, because normally in one municipality, they have sometimes 1 drives and there's not enough vaccine and everybody goes through. And loss of income and incurred expenses while being able to go through the healthcare facility. High level of trust in government. It was pretty much above 97% or to 100% who was they had high trust in government. There still was misconception, again, about the Ayurvedic medication, infertility, and that builds into the concerns about, we also had another question about other concerns, and most of them, almost 1/3 of the population was concerned about pregnant women getting the vaccine, having negative outcomes of miscarriage. And information sources was another part that we looked into in terms of communication. Most trusted was face-to-face communication, which was, again, something that our policy level people had also identified. And in terms of social media, TikTok was very used and trusted. Lastly, high coverage of vaccine, high retention of cards, high trust in the government, and the government did very well using the microplanning and also increasing the cold chain capacity. But however, there was inconsistency in recommendation. And this area, the lowermost, it has very high birth cohorts. So it's not a good sign that there is changing recommendation even in the same municipality. Then again, misinformation and concerns are still prevalent in the community. Face-to-face information sharing is the most trusted. And we have high level of dropouts in terms of getting the series. Lastly, we have done a dissemination meeting, and it was district level. We are planning another one at national level where we have INGOs and NGOs coming in as well. This is the 6 of us. And the funding was through 4 different grants, Saban being the major. And this is the first photo we took on the day of our training, and it was a very happy day, so I thought I'll end this presentation with that.
Thank you, Porcia. Thank you so much. Stuck to time and everything. Great presentation. The next presentation is from Julio Ichazo. And he's going to present, he's a project coordinator, and he's going to present first vaccine confidence and access index in Argentina, results and comparison from 2019 to 22. And I learned a lot just talking a little bit with him. And Argentina is one of those countries that actually has a lot of compulsory vaccination. And actually the interesting part is who gets vaccinated for what and whether people follow up. So we're going to learn a lot about that. Julio has a degree in sociology from the University of Buenos Aires and a master's degree in applied economics from Toccato di Tella University, Italy? Yes. And he actually does a lot of social innovation work with the Bunge and Born Foundation and leads a project related to early childhood, rural education, and health. He's a team leader for the Vaccine Confidence and Access Index that he's going to talk to us about in the context of lots of vaccinations and follow-up challenges. Thank you.
Well, first of all, I would like to ask on behalf of Bunge and Born Foundation, we are really happy to be here in despite of the jet lag and everything. It's an honor for us to have the opportunity to present our work. The Bunge and Born Foundation is a non-profit organization situated in Argentina that focuses its effort on the generation of knowledge and opportunities for social innovation. We understand this is a path to systematic solutions that are grounded in impact evaluation and have the potential to reach more and more people. We work on 6 specific areas: education, public health, sustainability, culture, heritage, and science. Before going specifically into our project, we would like to give some brief background about the vaccination coverage in Argentina and the South American region. The southern region has some of the highest level of vaccination coverage in the world. Despite this, many populations away from main cities are left behind. Inequality in relation to immunization coverage is observed, both between countries and within each country. We identify 3 main obstacles towards vaccination. There are the access barrier, the lack of information, and lastly, the factor related to the lack of confidence, not only in the vaccines, but also in the vaccinators and the decision makers. Regarding the healthcare system in Argentina, we are near 50 million of inhabitants, and Argentina has the GDP of a middle-income country with some social inequalities that are really considerable. The governments provide free healthcare, but also there are private health providers, so we have a mixed system. And lastly, we have 23 mandatory vaccines that are included in the national calendar. It's one of the highest of the region. Here we can see the vaccination coverage in the region. We see that for most of mandatory vaccines, the first dose has an uptake above the 80%. The problem comes when we see the second doses uptake and the consecutive. So, why is it important to measure the confidence index and the access barrier that the population has to face? Given the official data, we can know the vaccination uptake, and we can know how much vaccines are applied. But we cannot know the reasons behind any kind of fluctuations behind the uptake. So the main goal of the vaccine confidence and access index is to analyze the confidence in vaccines and also the access barrier that the population has to face. That is why we made up 2 different indexes, one confidence index and access index. We do this through yearly surveys that we apply to general population across the whole country, to more than 7,000 respondents. So, going specifically into the confidence index, we base our model on the confidence index released by the London School of Hygiene and Tropical Medicine in 2015. The index is composed by 3 variables: effectiveness, important for children, and safety. These dimensions were summarized in 1 variable using statistical methods. Something important to point is that the confidence index goes from 0 to 100, where 0 implies no confidence at all, and 100 implies full confidence in vaccines. We will see results by relevant socio-demographic variables such as sex, region, age, and also educational level. Now we are going to show the most relevant results through these 4 last measurements. Here we can see the general confidence index evolution through the years. In the 2019, the confidence was situated at 93 points, but after the pandemic, we can see a decrease that has stabilized near the 85 points. In 2022, we see that the confidence index was situated at 85.9 points. So there is a stabilization of the decrease observed after the pandemic. Here we can see the components of the confidence index. Effectiveness and importance for children present a decreasing trend since after the pandemic. And safety, this last measurement in 2022, shows an increase in the values that, given that is statistically significant, we can assume that the general index is stabilized due to this increase. Something interesting that we have found through the years is that the confidence index evolution by age shows us that the respondents, the youngest one, present a continued decreasing trend through the years, constant from 2019. So it's important to keep an eye on this specific group, since in the upcoming years, they will be the responsible of the vaccination of their children. Another fact that we have found is that the elderly, respondents of 65 years and more, present a volatile and volatile behavior, given that they were a group of risk during the pandemic. So far, the results of the confidence index. Now, going specifically into the access index, and given the importance of measuring accessibility and barriers that the population has to face, we adapt our methodology to follow the dimension proposed by the World Health Organization and the behavioral and social drivers. Behavioral and social drivers are belief and previous experience regarding vaccination that have the potential to be modifiable in order to increase the vaccination uptake. These 8 dimensions were summarized in one variable using statistical methods in the same line than the confidence index. These are the variables: availability of information, involved cost. Although in Argentina the vaccination is free, it also involves some transportation costs that should be taken into account when we consider the accessibility to vaccines. We also consider the ease of access to get the vaccination centers, the material condition to reach the vaccination center, rejection in previous visits, inconvenient vaccination opening times, and also we consider the waiting time in vaccination center, and lastly, success in being vaccinated in the last visit. Again, in the same line than the confidence index, the access index goes from 0 to 100. 0 implies no access at all, and 100 implies full access. Something important to take into account here is that following the recommendations of the World Health Organization, we only consider caretakers for this index, because the adults are responsible for the care of children below 14 years old that have a way more demanding schedule of vaccination than adults with no children. So caretakers face more difficulties and have a more close relation to the vaccination than adults with no children. Here we can see the first results for the year 2022. We see that the access index is situated at 66.9 points. We will be able to compare this in the upcoming years, but we see that there is a room for improvement. So, what are the missing opportunities in the accessibility condition of the population? We see there are inequalities regarding the region that can be boosted to increase the vaccination uptake. We also see, when we consider the access index by educational level, a clear trend where respondents with lower educational level present worse accessibility conditions. It's important to consider this because we can assume that educational level is a proxy of a socioeconomic situation. So in a way, it seems that most vulnerable respondents caretakers, seems to have the worst accessibility conditions to vaccines. Now, some conclusion that arouse from study. According to the data, the confidence is not a problem in Argentina, but it's important to keep monitoring to prevent possible variation through the years. Although confidence in vaccine is high, it seems that the youngest ones are a potential problem, since has shown a continued decreasing trend since 2019. Lastly, the vaccination uptake in Argentina, especially for second doses and upcoming doses, is more related to access barrier and in the inequalities among regions and educational levels. As the educational level goes down, caretakers are reported to have lower access to vaccine. In summary, we believe that studies like ours should be considered a public asset that help to boost the vaccination and focus the effort made by the decision makers and the public policy. This is the instrument and some characteristics of the instrument that we apply every year. And that's it for us. Thank you very much for your time and for your attention.
Thank you, Julio. It's interesting that regardless of how used a country is to actually give vaccination, there are still these bumps, and it's important to understand the complexities. Our next speaker is Saif Hadi, who is the Director of Global Access and Behavioral Research in the International AIDS Vaccine Initiative. He's talking to us about gamified behavioral experiments, how they can enable a deeper understanding of the say-do gap, and how we can actually learn from HIV more broadly. Saif Hadi is the director of this program, and he actually oversees policy research, market sharing, and demand generation. And I think it's really interesting that he actually works across different types of vaccinations. And when we briefly talked is that I did not know that a lot of our progress that we have on COVID vaccine is actually in part due to the development that actually 30 years of development on the HIV vaccine that is finally on the horizon, and many of us are very excited about it. So actually using his technique, it is going to be very interesting how we can bridge this say-do gap and learn more, and I'm actually intrigued to learn more about the gaming approach that he's going to talk to us about. Thank you.
Thank you so much, and I'm delighted to be here to be representing our partners, Humsafar Trust, C#, YRG Care, and Final Mile, as well as IAVI, on this important study on an age-old question. Why do people say things that they don't end up doing? And what can we learn about it? This is a question that has actually engaged a wide range of disciplines, from religion and philosophy all the way to psychology and science. And we're going to be leveraging the latter approach to dig deeper and understand why this happens, what can we learn from it, and how can we devise techniques to help address it. At the beginning, I'd like to acknowledge our donors, the US government, PEPFAR and USAID, for the advanced program that housed this study. And I'll be beginning by talking about some background information on the study and some key terms. This was done for a study involving not vaccines, but monoclonal antibodies, which are basically a corollary to vaccines. Vaccines are injected in you. They resemble something that looks like the virus or feels like the virus or elicits the same kind of response that a pathogen would within your body. And it's active immunization, so that to teach your body to respond to potential pathogens. Monoclonal antibodies are actually discovered from human individuals who have been infected with different kinds of pathogens, particularly highly variant strains like HIV, and over a long duration of infection and exposure to different kinds of variants. What results is that you have naturally produced antibodies in a small sample size of people that are able to neutralize the HIV virus across a range of different strains, hence called broadly neutralizing antibodies. Passive immunization is the technique that we saw in COVID, where initially people were donating their own antibodies to help out other patients. And then when that was proven to be less effective outside a particular window, there were artificially manufactured antibodies, most notably in the case of the US president when he was down with COVID infection. So this study was for antibodies and passive immunization. There are over 200 broadly neutralizing antibodies, or BNAbs, that have been discovered against HIV. And my organization, IAVI, has taken forward 2 of them into clinical studies. The second question is that, and this brings us back to a discussion from the morning today, how do we integrate supply and demand for vaccine acceptance? And this diagram represents end-user preference research. We see that across different products in industry. We see that in cars and handheld devices. We always give primacy to understanding the end user consumer of our products, what they want, what drives their decisions, and make sure that from the very design of our product, we actually integrate and inculcate these choices into the very design of the products. This is something that we also frequently do for biomedical prevention products, including vaccines, but we should do more of. And it should start right at the very beginning when you have begun the discovery of vaccines. And there are different benefits across each of the phases that have been highlighted in the study. In the early development phases, the focus is more on understanding what are the preferred characteristics that the end users would like from the product. And as you move ahead, how can we inform the design of clinical studies based on actually involving the communities most affected by the disease and the participants in those studies? And then towards the end of it is largely the last box that we're most familiar with, that we already have a product. And then how can we study end user preferences in order to have effective demand generation strategies? But in reality, it really needs to start much earlier. Say-do gaps, why do they occur? So a quick overview of that. The first thing is that, human choice is never stable. It's always in motion. We like something today, we don't like it tomorrow. And then the same applies in the case of a lot of health choices that we make. And they're informed by by much more than changes in human behavior or outlook. So there's obviously the person, but the person is interacting with the product and its characteristics, where it's being delivered, how it's being delivered, and then also the environment at large and what are some of the changes within the environment. It's this complex integration of all three of these spheres, each one of which is in a constant state of flux and motion. So these are all evolving together, and that's what the dotted lines are trying to showcase. And it's due to changes in either one of these spheres that you have a potential of people saying things that they would not end up doing. In addition to that, a lot of our studies and research is conducted in controlled environments, and they have limitations in their replicability of real life scenarios and situations. And so consequently, we see a lot of these gaps because of that. And then in addition to that, a lot of the studies, inevitably, they put the participant in a scrutiny or kind of a witness box. They feel like they're being analyzed, and their responses are consequently tailored to this, feeling of being scrutinized. So, and they're also human decisions are based on an integration of conscious and non-conscious drivers of choice. In 2013, Daniel Kahneman and others won the Nobel Prize for this, System 1 or System 2. So it's a mix of both reasoned out thinking as well as feelings and emotions and other things. And a lot of our research, unfortunately, has limitations in terms of what it can capture in terms of non-conscious drivers of choice. And then finally, there are subjects of social taboo or where participants feel judged. And this is more true for vulnerable populations or populations with increased vulnerability, where they feel pressured by different kinds of environmental and contextual factors, and that influences their responses in study conditions. All of these together contribute to stated preferences not being equal to observed behavior. With that background in mind, I'm just going to give a quick overview of what are gamified behavioral experiments, how do they use simulation. So at a very high level, they combine 4 distinct factors. The first is the power of storytelling. And we heard today in the morning how vaccine hesitancy networks actually leverage storytelling a lot more than pro-vaccine people. And the effect of this in research design is that the question is not direct about what would you do or what would you not do, but it's actually through the medium of characters and story. And so that feeling of being scrutinized or that difficulty of asking questions, which are as they apply to your personal life, is alleviated by doing that. The second is the introduction of gameplay, and there are various game components like competition and levels and play and rewards and so on and so forth. And these allow you to both switch on your non-conscious drivers of choice and be less conscious, and also have this, feeling of depersonalization, that I can answer on someone else's behalf, or I'm a character in a game, and this is responding to a gamified scenario. In addition to that, there are also aspects of user experience which tone down the cognitive load of questions and ease out, it's multisensory, it's immersive, it's interactive, and consequently it's easier to understand, and also a little bit, more replicative of real life situations and circumstances that happen through simulation. The last point here is that, once the experience in the gamified experiment is completed, there is room for, rumination and discussion and, decoding some of what happened there, and that provides a lot of learnings as well. In terms of methodology, I'm going to be very, very quick for this because I want to focus on some of the findings and implications. We've used a widely accepted framework of acceptability from Sikon et al., published in 2017, and coupled it up with more frameworks. The research design, the one side of it was focused on qualitative research. I will not be presenting the findings of that today, but the second side is really based on the gamified research. And the sequence is such that, you begin by identifying what would be like, some of the variables influencing acceptance and choice of vaccines. Then you actually create a few choices of products, bundles of choices, and you ask them, what would you prefer? And they don't have all of the ideal choices that they mentioned in the first phase. So they have to necessarily make some kind of trade-offs, and you try to understand those trade-offs. Based on that, you have this immersive experiential walkthrough of what would, the burden and benefits of these choices look like in a simulated gamified condition. And then you have the guided reflection that enables you to really identify how are you constructing your choices and what may be potential avenues for reversal there. The study was conducted across 3 different parts of India, in Mumbai, in Chennai, and New Delhi. It included 5 different populations that are relevant to HIV research, which is female sex workers, men who have sex with men, transgender women, people who use injectable drugs, as well as adolescent girls and young women who were living in a high-risk environment. The bundles of choices from the second phase were modeled after real products, and they included these broadly neutralizing antibodies, which will be delivered as 2 injections once in 2 months, and then other choices such as an oral pill, an injectable version of the oral pill, as well as an implant. The idea here of the actual gamified experiment was that there is, you have a musical chairs kind of a system where a person gets selected, they pick a card, the card can be a chance card or a scenario card. The chance card will take you into gamified fun kind of scenarios that you play around with. It's necessary to keep you, constantly in a hot state. And then the scenario cards actually mimic real life circumstances. These are created separately for each one of the target populations in this study, and they mimic certain scenarios that were constructed using the qualitative phase, which are likely to happen using mental models or heuristics or biases that are well known. And once you've played enough of these scenarios and the game ends, your points accumulated through the play can get converted into in-game rewards, and there is a reflection discussion, as I mentioned. In terms of implications of this, there are some key implications. I'm going to just try and summarize in a few quick minutes what they are. So we know that the goals that people have with respect to product use are first and foremost targeted towards effort, reduction or minimization. I don't want to undertake a lot of effort to access this product. I want to have as much control as possible. I want to maximize privacy. I want to avoid stigma and make sure that any pain or discomfort is at a minimal. Now, with this, some of the key mental models that informed that we were able to derive and learn from the experiment was that intrinsic pleasantness is something that is a consistent driver of choice. People felt that some of the pills that they were using were large and had a bad taste, and that and they needed to take them every single day, and that burden of a routine was something that they did not want to follow. In terms of efficacy, their experience was that injectables were only used when shit hit the fan, when the situation aggregated, and so consequently they're faster acting and they're more efficacious. Then there were also models around that that you have to stand in line to get anything delivered through the clinic, like an injectable, but at the same time also it has better privacy because pills in a cabinet at home can be discovered by other people and can lead to stigma. due to shortage of time, I'll just quickly move ahead as well. So we did an analysis of, both the emotional factors that we could learn and the rational factors that we could learn through this. Within that, 3 of them, the ones in dark green are the positive ones, and the ones in a red kind of color are the ones that are negative. In terms of positive drivers, the fact that, privacy through injectables is maximized, the effort, secrecy or and the stigma associated with pills and antiretrovirals and HIV is avoided, and there are fewer doses. These were the key drivers for using injectables or choice of injectables. In terms of the barriers, it was the fear of needles, the amount of memory burden for remembering something every 2 months, and the loss of opportunity that can happen. And then, and this gave us access to conundrums, the push and pull that was happening both in terms of feelings, emotions versus reason, but as well as the positive drivers versus the barriers themselves. And they allow you to construct preferences in terms of why are people choosing what they're choosing. And then that leads to trying and understanding what might be certain pathways to reversal of their choices. So for example, from rejection to acceptance, we understood that, non-familiarity of antibodies as a class of product led to mistrust. But then if that was addressed through appropriate information and social proof of enough people and influencers using that, that would lead to recalibration where they would consider, antibodies as the less risky choice and would lead to conditional willingness. And then the second part is that, from willingness to unwillingness again, that, that in the face of wavering motivation, they already have a choice, but, the immediacy of the burden of that choice versus the distal nature of the benefits of exercising of the choice was the clear reconsideration that was done. And lastly, in terms of just 3 quick lessons that we can take from this, the first is that this can complement quantitative and qualitative methods of inquiry to deliver deeper findings. The second is that the same methodologies can be actually used to influence behavior change, not just understand pseudo gaps, but influence change there. And the third is, with the advent of augmented reality and virtual reality, there's a lot more that can be done in terms of immersion. Thank you so much for patience.
Thank you, Saif. That was very interesting. I've never thought of gaming as a modem or as a modality to improve vaccine uptake. So this is very interesting. Our final speaker today is Dr. Stefan Mandic-Racevic. He's in the Social and Behavior Change Specialist at JSI Research and Training Institute. And the title of his presentation is to develop a behavior-led strategy to integrate COVID-19 vaccination into life course vaccination and healthy lifestyles. So I'm going to ask him to come, and while he does, I'm going to introduce him a little bit. He's a doctor of medicine in occupational medicine, industrial hygiene from the University of Milan, and is using his research in informatic management, behavioral and cultural insights in various European countries where he collaborates, including in Asia. He's certified WHO infodemic manager. He works with EDC, WHO informatic research electronic data capture, and is the administrator of the Faculty of Medicine at the University of Belgrade. Thank you.
Thank you very much. Well, I was hoping to use Julio's time because he finished earlier, but then Saif stole it from me, so I'll try to be quick. I will talk briefly about the background and what is Europe and Eurasia region and some country specifics. I will explain the methods, especially about behavior integration approach, how we did our research and how we created these behavior profiles that I will show, and then show the results of quantitative and qualitative research and the strategy that we developed and how we validated it. I will finish with some recommendations and conclusions. So, what is this Europe and Eurasia region? Our project is currently active in the Europe and Eurasia region, which covers at the moment Moldova, North Macedonia, Serbia, and Bosnia and Herzegovina, although Bosnia was not included in this research. What happened with COVID-19 in this region, where there were different approaches to the pandemic and the reaction to the pandemic and the reaction to the vaccination. Unfortunately, the region has suffered a lot lot from years of life lost due to the pandemic, high number of cases when you count in, when you standardize per the population, high number of deaths from COVID. And the approach differed between countries, although it was similar at the beginning, kind of ignoring the pandemic, then stronger reaction, lockdowns. When the vaccine became available, here you can see the first line, the green line on the left is Serbia that got really early, the vaccines were available, and a few of us, the first few million, we got vaccinated in the first few months, and then it completely stopped, and it hasn't moved since. A similar situation was seen in North Macedonia and Moldova, so in each country the vaccination, the COVID-19 vaccination has reached a plateau and hasn't moved since. What is our program objective? The Momentum Routine Immunization Transformation and Equity project of USAID. We are working to contribute to increase uptake of the COVID-19 vaccination in these countries, and we are trying to work with priority populations to correct mis and disinformation, which has been one of the most important factors reducing vaccination, and use behavior change communication and media focus strategies to do so, and at the end also to foster communication between the countries and try to learn from each other and see how we can improve immunization. So our methods are based on behavior integration, and this is a method widely used to design, implement, and evaluate activities. What is behavior integration? Well, in short, we focus firstly on what people need to do to overcome the obstacles to a specific behaviors. We try to identify different factors that influence this behavior and design and adapt interventions that can be used in the specific context. How do we arrive to this? Well, we have 3 phases. The first phase is formative research. So this is research needed to inform our behavior profiles and later our strategies. We have done quantitative research through a premise platform in Serbia and Moldova, but we also use published research. We don't mind using other people's research as long as it's published and it's done well. And we have done qualitative research through stakeholder and key informant interviews, interviews with priority populations, and of course other people's published qualitative research. As far as this formative research, the surveys, the quantitative research was done through a premise platform. The premise is an online platform where users do small tasks like filling out a questionnaire for a compensation. We have covered people's beliefs and attitudes towards vaccination, social processes, practical barriers, etc. And we have done this in Serbia and Moldova where this platform is available. As far as the qualitative research, we have done in-depth key informant interviews with people from National Institutes of Public Health, Ministry of Health, professional health associations, healthcare workers that worked on immunization, academia, and other representatives that could offer valuable information on the various factors, barriers, and motivators to immunization. The second phase included creation of behavior profiles. We used the Think Big platform that's freely available to anyone, but was developed by the Manandhar group. We tried to understand which are the motivators and to leverage them, to reduce barriers and involve supporting actors, and this platform allows a very nice way to organize all this data from the research and understand which are the supporting actors, which are the barriers, and what strategies could help reduce the barriers and increase the motivators to vaccination, and also to develop an action plan. We have identified through our work in countries different behavior profiles, and the profiles are based on a specific behavior that the target population needs to do. So we have focused on pregnant women, elderly with chronic diseases, healthcare workers as people that should receive the COVID-19 vaccination, but also on healthcare workers that should recommend the COVID-19 vaccination, so they also have a behavior profile that we worked on. This is a screenshot of how what the platform looks like when you fill it with different motivators and barriers, and what you see in yellow is a pathway to change, so how from a specific barrier, what would be the supporting actors and what would be the strategies that you can use to achieve the specific behavior that we're interested in. At the end, we worked on validating the approach through participatory workshop, concept testing, pre-testing. So, for the validation, yeah, we use this participatory workshop, so I won't spend more time on that. What did our qualitative research show? Well, COVID-19 is one of many priorities. That is a big problem, because if you have many priorities, it means that COVID-19 is actually not in the focus of the government or the populations. The priority populations for COVID-19 vaccines are the same as for the flu shot, so elderly, people with chronic diseases and pregnant women, and it was important to align with general immunization strategies. The patients listened to their healthcare providers' advice, but they were not getting the advice to get vaccinated from their healthcare providers. The patients very often wrongly believe that they are not eligible due to allergies, pregnancy, or chronic health condition. There was a lack of quality and reliable health information provided to patients by their provider about COVID and COVID-19 vaccination. And of course, healthcare providers indicated that they lacked information and training about reliable sources, and this fueled their hesitance. As far as quantitative research, vaccine acceptance was significantly lower among pregnant women and people with chronic diseases. People with chronic diseases were likely to believe that the vaccine is safe, but less likely to believe that the vaccine is safe. They believe that it could increase their risk of dying from their underlying condition. They were less confident in healthcare workers. They had less trust in their healthcare provider recommendations. For pregnant women, also they were less likely to trust their healthcare provider, and they were less likely to follow healthcare providers' recommendation about vaccines, and they were much more concerned about vaccine safety. For Moldova, there was not a specific difference between pregnant women, people with chronic diseases in their perception of vaccine safety. But also it was clear that there was support necessary both for healthcare providers and for the patients. So what have we done? The QR codes lead to actual interactive behavior profiles. So this gives you an opportunity to see how you can use the behavior profiles. The priority behaviors I already mentioned were patients with chronic diseases getting the COVID-19 vaccine, healthcare workers getting the COVID-19 vaccine, pregnant women getting the COVID-19 vaccine, and then also primary and secondary healthcare workers recommending the COVID-19 vaccine. So we were working on how we could stimulate this kind of behavior, how we could arrive to this kind of behavior. The main supporting actors were Institute of Public Health, Ministry of Health, Pharmaceutical Regulatory Agency, professional chambers of healthcare workers, health professional associations, patient organizations, and civil society and community-based organizations, and of course media and journalists. And what were the critical factors? At first we had more than 30 critical factors, but we focused on those that we could address in our work: time for counseling, legal obligation, trusted institutions, data availability, safety concerns, efficacy concerns, trust in healthcare providers, prejudice, knowledge about vaccines, side effects, contraindications, and interpersonal communication. And you can understand that this prejudice, the last three, are connected to healthcare workers. It's difficult to recommend to someone to get vaccinated if you're not vaccinated yourself, or if you don't have enough knowledge to answer any questions, or you lack interpersonal skills to answer the questions in a nice way. So what are our main challenges to developing this strategy? There was a COVID-19 fatigue. We are working in Eastern European countries where COVID was not considered as serious from the beginning. So imagine at the end of the pandemic how difficult it is to push a strategy for COVID-19 vaccination. There is, of course, a different level of involvement and the will to be involved from different actors, from complete unwillingness to be involved to support, and local circumstances different between districts and municipalities in all the countries of the E&E region. There are some opportunities. For example, the priority populations are same as for the flu vaccination and for general health promotion for people with chronic diseases and pregnant women. So this is something we could work with. Health promotion is aligned with national health priorities. So national health priorities in the countries are, of course, cardiovascular diseases, cancer, safe and healthy pregnancy. So this is something that we could use when developing our strategy. And then what was our solution? We tried to integrate COVID-19 vaccination into a vaccination package, which is part of healthy lifestyles. This shows a clear benefit for the patients with chronic diseases and pregnant women, because who doesn't like to have a healthy lifestyle, to live longer, to be healthy, to have a high quality of life? And this is why it's aligned with health priorities of our target population, but also it makes it easier for the healthcare providers to even discuss COVID-19 vaccination, because initially they were thinking, so I need to talk to these people that have other problems, other priorities. I have to talk to them about COVID-19 vaccination. It's going to be a problem. They don't want to listen. But if you put it in a nice package of other things that align with their priorities, it's easier. And this opens the door for health promotion for other topics, not just COVID-19 vaccination. So this project can live on after its lifetime. How did we do the validation? We organized concept testing of key messaging, healthy lifestyles approach, how it fit with national priorities. We checked with the stakeholders from the Ministry of Health, Institutes of Public Health, how they see this, and they had an aha moment. So this is something we could do, and actually it's going to be seen as a positive activity regarding COVID-19. So this is why we developed a continuous medical education curricula for healthcare workers, including physicians, pharmacists, and nurses, with 3 sections: healthy lifestyles in general, immunization and COVID-19 vaccination, and quality health service, so person-centered care, so they could deliver this information in the best possible way. We developed a community engagement approach with the community-based organizations, and of course we're working with on capacity building of local health promotion or public health practitioners. What are our recommendations and conclusions? Well, it's important to design every research with a purpose. We have used available data, and as needed, we have collected additional data, both qualitative and quantitative, which has informed our behavior profiles, which later informed our strategy. We use this data to identify the barriers, the motivators, the key supporting actors, and their actions, what could support COVID-19 vaccination. This behavior integration approach can be really well applied to COVID-19, but also to other situations. The use of the Think Big online platform helped design an evidence-based strategy, and it's really easy also to show how each of the parts of the strategy flows from the others. But also this addressed the service experience challenges and barriers across 4 areas: community, systems, health facility, and health workers and client relationship. And if you want to learn more about the service experience, we have a side event tomorrow at 4:30 in Ballroom 3, I believe. The final thing is we co-designed our strategy with key stakeholders. So they took ownership of the strategy. We worked on validating the approach through user testing, first with the key stakeholders, but later also with medical doctors that are supposed to deliver this talk to their patient, and we ensured that the strategy aligns with priority needs within the country. And for more information, feel free. The first QR code is to send a WhatsApp message to me. We can chat afterwards. You can check out our website. And really tomorrow, if you want to join our service experience event at 4:30 in Ballroom 3, you will learn more about service experience and what it can do with your work. And thank you very much for your time.
Thank you, Stefan. So the next part of our session are some questions, and I'm going to start out asking some questions from each of the presenters, and then you get a chance. And the way we're going to do it is that we want you to raise your hands, and then somebody's going to come with a microphone, and then we want you to go ahead and state your name, your job title, the company or the country you are representing, and then ask your questions. But again, I'm going to get started asking a few questions of our presenters right here. So Porcia, you talked to us about sort of the rural data collection in an isolated middle-income country. low-income country. What were some of the common findings? Because you had 3 aims. Remind us what the aims were and what were some of the common findings of what you actually found worked out for you?
There you go. Yeah, the conceptual framework itself was chosen so that we could look at 3 different stakeholders from a wider policy level. Then we go to the healthcare facility level, and then we move to the household level. And one of the common findings was that hesitancy is not a big issue because people had very high trust in EPI for childhood vaccination. So when COVID vaccination was given out through the same micro-planning, it was, people were like, okay, this is trustable, it's from the government. And we're coming from a country we love talking about the government's corruption, this and that, complaining, that's the right word. And to have such a high confidence in terms of when I asked about vaccination was like, it's pretty neat. Like they would say yes, like even the unvaccinated people was like, yeah, there was this reason why I didn't go, whatnot. But this data collection was in middle of 2022, July 2022 to the December. So we were at a point where people were taking boosters. It was just coming into the country. And so people already had like, oh, I've seen my neighbor take it. Of course I will do it too. And these are like, we don't have huge buildings. This is very secluded from the capital, where most of the focus goes in. So it was nice to know that what was happening in the district level, and when we talked to the stakeholders in the public policy level, these were people from INGOs and foreign consultants working for INGOs and the EPI managers and advisory group people. They were well aware, like, our main issue is the booster. So we were seeing that from all 3 different levels. But hesitancy and acceptance was, if people had the opportunity, they will take it, yeah.
Actually, thank you. Thank you, Porcia. Now, Julio, you came from a country where there's a lot of vaccines, goodness, more than 20 to take by the time you're a young adult. Do you think that confidence was accepted with the pandemic? Because you really have this whole smorgasbord board that you actually expect people to do, and what influences did you see COVID had?
Yes, we believe that in some point the pandemic affected the confidence. We can see in the data the confidence after the pandemic. We were quite lucky because we did a study in the year before the pandemic, like a normal year. And after the pandemic, we realized that the confidence has decreased. But given the data that we count, we cannot attribute directly to the pandemic. But it's really possible that the pandemic situation and all the public discussion around the vaccines and, again, the corruption in our country is quite common too. So we believe that in some point that affects the confidence in vaccines, in the decision makers, and in vaccinators. So that cocktail makes us believe that the confidence has decreased after the pandemic, because it's not only related to the COVID vaccine, it's impact in the confidence in general of the vaccines, even in the healthcare system providers. So it's interesting to see and think how can be the confidence increase again, especially again for the youngest one.
Yeah, it's interesting that it actually also affected the healthcare providers standing, and I think I've never really seen much published on that, but I think it's in general true that healthcare providers have taken a hit.
Yes, of course. It's quite common that the people, especially in Argentina's case, the people blindly believe in the vaccination and in the healthcare providers. Now, after this massive discussion, public discussion, the people start to doubt about the vaccines, the healthcare system in general, and it's quite common to expect this lack of confidence. But the important thing is to think new ways to communicate, as the guys here commented, and improve the vaccination confidence, again, to previous levels. In Argentina, we are quite lucky to have high level of confidence. It's important to get back to that levels.
Thank you, Julio. Now, you pointed to your colleague, Saif, and gaming is a new approach, and I was very surprised to hear about it, and I'm even more intrigued that it came through HIV/AIDS, but you were telling me that a lot of new innovation has come through HIV/AIDS. So what is the value of the end-user preference research in the product development process, and how can that help in COVID-19?
Right. Thanks so much for that question. And I think what I was alluding to is that for almost any kind of, commercial products that we all use, there's a lot of thought that's gone into really understanding who's going to be using this product and what exactly is their need, what are some of their behaviors that we can understand so that we make sure that people continue to use this product and its future versions. I think that the whole point of end user preference research is that we need to do the same for health interventions and especially for vaccines. So we really need to do the thought process for engaging with the end user populations or communities needs to start from the get-go. They don't need to be engaged as mere objects of study, but as equal partners in co-designing that research. So they're your helpers and your co-partners in trying to understand what might be the best pathways to follow in terms of both designing the actual product, because in vaccines we have a lot of innovation happening right now. There is intranasal vaccines, there is recently a study highlighted, microneedle patches getting approved. There are gel-based vaccines in the pipeline. So there's a vaccination of tomorrow is going to be unlike what we know vaccination today. And we need to make sure that we're really understanding and responding to people's needs from the very get-go early on in terms of how to understand and then address those needs through the next generation of vaccines and health interventions.
Thank you, Saif. Now, Stefan, in a way, you had very different approaches to similar issues, right? Because you use co-development to package lifestyle as a transition to get people to adopt COVID, and you packaged gaming for people to depersonalize, being able to go through the decision-making process. So from your perspective, what was the reaction of the various stakeholders in your proposed approach, and how did they enjoy and how did you arrive at it?
Yeah, thank you very much for the question. Yes, we were our work started in a very hostile environment. When you started talking about COVID-19 vaccination, where really less people were paying attention to COVID-19, they were just saying this is not going to work. There's no way this is going to work. So with these prompts, and unfortunately we didn't have the opportunity of using some innovative techniques, but maybe we could have learned using gamification, we could have learned more. But with additional prompts, we understood that first we need to focus on what's important for people, what's important for the government, and that wasn't COVID-19 at that point, and how we could create something that nobody can say no to. And actually this is what we created. We tried to create a product, if you want to call it like that you are not ashamed, and health workers were in a way ashamed of promoting COVID-19 vaccination because patients were saying, we have other problems, man, we don't want to hear about that. And this is something that they can proudly present and say, well, this is something that's part of your healthy lifestyle. You should do your checkups. You should monitor your weight. You should be physically active. And also immunization and life course immunization is part of that. You want to live longer. You want to be healthy. This is part of that. And this is why I think we got this positive reaction from the stakeholders. And even those that were not so positive, they weren't negative. I mean, at the minimum, they had to be neutral. And they had to say, well, it's not bringing anything bad to the table. It's bringing something useful. So this was the approach, and we hope it's going to give some good results.
Just a quick follow-up question. I asked you earlier whether or not you thought that healthcare personnel took a hit in this whole pandemic. What I hear you speaking to is that this is actually a packaging that helps them quite the opposite, right?
Well, what we have seen is that patients actually want to trust their healthcare provider, and they want to see that their healthcare provider is informed, that they can answer their questions, etc. Healthcare workers took a hit because they were sent to battle without any actual arms. They weren't trained to answer questions, they weren't trained to work with misinformation, they weren't trained to explain how science works, because we were used, and we heard that at maybe at the keynote, that we are used to just saying to our patients, you should do that, and they just do it. So this kind of challenge was really challenging for our healthcare workers, but this way, you know, our leverage, one of the rare motivators we had was trust in healthcare workers. So we want to increase the trust in healthcare workers by showing that they know their stuff, they know how to explain it, they do the right thing for their patient, and then the patient, when they leave and they say, thank you for this, doctor, you know, the healthcare worker will feel happy that they provided this service. If not, if they feel like they're fighting, they're, you know, rowing against the stream, they will never promote any kind of vaccination, not to say COVID-19 vaccination.
Thank you so much. I want to open it up to the audience. As I said, come to the microphone, introduce yourself, who you are, and feel free to have a question for any one of our speakers. You don't have to be shy. Come on, please. I know the room is a big room, but we're a good group.
Yeah, thank you for the opportunity and the great presentations. My name is Christo. Yeah, I'm a doctor from Indonesia. Sorry, my apology. Yeah, we founded and manage vaccination clinics in Indonesia. So I want to ask to Dr. Stefan. Yeah, talking about the vaccination into life course vaccination and healthy lifestyle. Well, I want to ask was, did you only talk about COVID vaccine related to healthy lifestyle? Is it the thing that you promote as part of the healthy lifestyle, or have you already also designed and integrate some of the vaccines into life course vaccination in your program? And should you have done that previously, maybe you can share, because we are very interested in creating some sort of like product, yeah, that you said, like how to integrate the whole vaccination series into becoming a life course vaccination. And also for Dr. Saif, yeah, maybe you were talking about gamified behavioral experiment, right? Have you also done this kind of gamification thing to increase vaccine acceptance in practice? I mean, not only in research to design a vaccine product, but also in practice in improving vaccine acceptance. Thank you.
I will be really quick. We have thought of other vaccines, and the first one, of course, that comes is the flu vaccine, the seasonal flu and pneumococcal vaccine. And this, we have left this as an option for the healthcare providers, depending on their patient situation, to offer other vaccines. And at the end, this is also increased acceptance of our program, because they're able to take as much or as little as they want from the package that we offer, and they are the ones that can estimate what is the best for their patients. So we are not forcing anyone to promote any specific vaccine, but we are just trying to introduce this option as part of a healthy lifestyle, thinking also about life course vaccinations, and as I said, not only COVID-19, but other vaccines. And they are able, this is our idea, was the projects, you know, finish. And this is something that can stay with them, and that's something that they can adapt then to later vaccinations. They can add HPV, they can add other vaccines through the same lens of healthy lifestyles that include not only different parts, but also a specific vaccine. And I finish here.
Thanks for your question. Yes, we have used this to actually influence vaccine uptake behavior. And there are 4 or 5 different modules of games that we have developed. We've just talked about, you know, a very small piece of this work. I'll take just 30 seconds to talk about a quick example for adolescent girls and young women. One of the key barriers is, self-efficacy. Can I do this? Can I take this decision on my own? Is it going to benefit me? How do I go against peer pressure or social pressures? So we've created a game, both physical games and digital games to actually deal with the challenges that adolescent girls and young women face in terms of gaining access to vaccines and uptake of vaccines. We can talk about it offline in terms of details.
Thank you. Any other questions from the audience? Yes, thank you.
Hi, thank you for the presentations. I'm Nikki from Takeda, and I'm based in Singapore. I had a couple of questions for Porcia, I think, and Julio. So I see that a lot of the interventions you were discussing is focused on childhood immunization. So although you had the different age breakdowns, Julio, about vaccine confidence, the question was still about whether the vaccine is good for children, whereas from a perspective of a caregiver. Are you planning any separate studies that's really looking at their own intention for adult vaccination, the caregivers themselves, or is it still very much focused on the childhood immunization? And Portia, I know the community workers, they're really leveraging the EPI sort of micro-planning. So do you think post-COVID, this can be transitioned to adult vaccinations as well?
Thanks for your question. Regarding the specificness of the safety and effectiveness and safety for children, important for children, we apply the same question to all, to caretakers and to adults with no children. So the idea from them is to see if the general level of confidence is fluctuating through time. Not only for caretakers, caretakers are only considered separately for the access index. This is in a way following the recommendations of the World Health Organization. When we saw the results putting on one side caretakers and on the other side adults with no children for the confidence, we found no differences. So it seems that in the case that you consider yourself, you are not you don't have doubts regarding the effectiveness, importance, and safety of the vaccines. So it's important to keep an eye on it, on consecutive medications. But for now, this is the first time that we applied the same questionnaire, and we split the responses by caretakers and non-caretakers, and we found no differences. But maybe in the near future we can see a change in that situation.
Right. So the FCHVs, the community healthcare workers, are also the ones who hold the fort for ANC visits. And that's when you can get maternal tetanus vaccine as well. But Nepal is a country where we don't have any adult vaccination platform. Like many LMICs, we're still focused on childhood. But except the maternal tetanus vaccination program, and the compliance is very high. And we were hoping, so with this 26,000 households that we have, we're really hoping to go back to only pregnant women, because this was a mixed bag of it. And we're trying to get the dates if the minute they had in postpartum visits. We're hoping to do the study after, next month. But basically, we're trying to go and see if they have dates from their cards that we could see that if it aligns when they go for ANC visits for tetanus, as well as after like how compliant they are first for tetanus. Second, to see when their child grows within that first year, how often do they go, how often do they have contact with the healthcare facility? Because that's another way of looking at, could we use this for COVID if we can catch women, and also once you catch the woman, you catch the household. So thank you so much for your question.
Thank you for your question. We've come sort of to the end of the session, but I think what was really interesting is that the session, if you look across the various presentations, really has looked what COVID, kind of post-COVID learning is and what we can take to move to address broader issues that we actually now have had the opportunity to study and kind of see what we can do to address the changes that came or laid bare by COVID. So I want to thank you very much for your time. I want to remind you that right now when we are done, we're going to applaud, I think. We're going to applaud, but we also have a break from 3:45 to 4. And then the next activities are the poster sessions that many of the other participants in this conference are actually sharing. It's going to be on routine childhood immunization and live course vaccination at 4 o'clock. Okay, so thank you very much for the speakers, and I'm excited about the next things to come. And if you have questions, they're right here.